Live.
Hello and welcome to the World Massage Conference. I'm your host, Scott Darnell, along with my co-host, Eric Brown, for this presentation, Understanding the Iliopsoas Muscle with Greg Morling. Thanks to our global sponsor, Massage Envy. Massage Envy offers a steady client flow, competitive wages and benefits, full and part-time positions, and a respectful, positive working environment. To apply for a position near you in the United States, visit www.massageenvycareers.com. Thanks to our daily sponsor, the National Certification Board for Therapeutic Massage and Bodywork, defining standards and providing certification exams and programs for professionals for over 17 years. Learn about their newest initiative, Advanced Certification, by visiting www.ncbtmb.org. I would like to sorry about that for just a second. I'd like to introduce our guest. Here's a great opportunity to learn some detailed information for working on the iliopsoas muscle. This presentation will focus on the practical working protocols related to the assessment and treatment of a contracted iliopsoas muscle. Learn some of the theoretical background during the practical presentation with references to the possibility of reactive psychosomatic response when the treatment becomes too intrusive or painful. Greg is an international presenter at major conferences in Australia and New Zealand, who has been teaching for many years with over 24 years in clinical practice. Greg is the past president of the Australian Association of Massage Therapists and is known for his work in massage for those with Parkinson's disease. His recent research and clinical focus has been on developing new massage protocols to honor the enigmatic iliopsoas muscle by avoiding a reactive response during treatment. Greg, welcome to the World Massage Conference.
Thank you very much, Scott. It's lovely to be here, and thank you for having me. To everyone out there as well, thank you for joining this presentation. As Scott mentioned, my name is Greg Morling. I'm a remedial massage therapist from Sydney. My presentation will cover the theory underpinning some new gentle massage techniques aimed at treating a dysfunctional iliopsoas muscle. The iliopsoas is sometimes called just the psoas, but I refer to it throughout my presentation as the iliopsoas. This presentation will take around about 30 minutes, and I truly welcome any feedback or questions that you might have relating to my work. One of the most enigmatic muscles in the human body is the iliopsoas. Travell and Simons name it as the hidden prankster, and I suspect that a significant number of massage therapists are puzzled about how to manage this prankster in the clinical setting. Just like one of Pablo Picasso's Cubist paintings, it possesses many angles and ambiguities that makes it fascinating and profoundly difficult to address and treat in our practice. Some of the conditions involving the iliopsoas muscle include lower back pain, sacroiliac pain, sciatica, disc trauma, scoliosis, hip and knee pain, menstrual pain, and digestive problems. We may also include biomechanical problems including pelvic tilt, leg length discrepancies, kyphosis, and lumbar lordosis. This presentation will cover a range of issues associated with the iliopsoas, including the different views surrounding the function of this muscle, the relationship it has with so many other parts of the body, and its role in initiating the fear reflex in your client. Next slide. Position. The psoas major, psoas minor, and the iliacus muscles combine to become the iliopsoas. The psoas minor is present in roughly 40% of the population. If present, psoas minor assists in a superior rotation of the pelvis, an action opposite to psoas major. Psoas minor is a vanishing muscle disappearing as we evolve from a semi-flexed to an upright being. Psoas major and minor both insert together on the lesser trochanter of the femur. There are two psoas major muscles attaching to each side of the transverse processes of all lumbar vertebra, L1 to L5, and the bodies of T12. All lumbar vertebra are innervated by branches of the L1 to L3 lumbar spine nerve roots, and there has always been an anecdotal relationship between the iliopsoas dysfunction and inguinal pain. Iliacus originates in the superior two-thirds of the iliac fossa and the anterior ligaments of the lumbosacral and sacroiliac joints and insert into the lesser trochanter of the femur. Move to the next slide, please. Function. Iliopsoas is considered by most therapists to be the main hip joint flexor. It flexes and laterally rotates the thigh, exemplified in kicking a football. The iliopsoas muscle works in tandem with iliacus, rectus femoris, pectineus, tensor fasciolata, and sartorius. Acting from its insertion at the lesser trochanter of the femur, it flexes the trunk, such as in rising from a supine position. As well as flexing the hip, the iliopsoas muscle can assist extension of the lumbar spine, increase lumbar lordosis, and it plays a significant role in maintaining upright posture. Many would also argue that a dysfunctional iliopsoas contributes significantly to back pain. Ida Rolfe wrote that the psoas does not bulge forward, it lengthens and falls back within the abdomen as it flexes. There is some controversy here concerning exactly what the iliopsoas muscle achieves when it flexes, and perhaps the question is whether the iliopsoas muscle is contracting and lengthening at the same time by utilizing individual fibers within the one muscle. Thomas Myers offers a similar suggestion in his writings on this enigmatic muscle as well. In his opinion, the iliopsoas is a major flexor of the hip and may well be operating on the lumbar spine as one muscle, but with opposing functions and forces within it. Not unlike the deltoid that engages one or all of its three compartments during movement. Professor Nick Bogduk, an Australian researcher from Newcastle University, has been the major influence and world authority in this area over the past 10 years, and asserts that biomechanical analysis reveals that the psoas has only a feeble action on the lumbar spine with respect to flexion or extension. He believes that the psoas has its major function as a stability muscle for the lumbar spine through axial compression. Other researchers around the world have shown agreement with Bogduk and developed his theory further by arguing that this axial compression fixes the spine in neutral alignment while longitudinally pulling the head of the femur into the acetabulum. Yoshio, another respected researcher, concludes that the primary role of the psoas major is lumbar stability, and that it contributes very little to hip flexion at all. Myers' insight, Bogduk's research, and my own clinical experience influenced the practical component of this presentation. Next slide. Reactive response to perceived danger, the other role of the iliopsoas muscle. It is well recognized by scientists that when the body experiences shock, trauma, or great danger, it may go into a freeze. Not unlike the mouse trapped in the cat's claws, the human too may be in a state of immobility when in shock. This is one of the three primary responses available to reptiles and mammals when faced with an overwhelming threat. The other two, fight and flight, are better known to us. The mouse goes into the immobility state as a last-ditch survival strategy. There may be a possibility that the cat will be distracted, and in that instant the mouse may awake from its frozen state and make a hasty escape. The mouse is able to discharge the vast amounts of reactive compressed energy following its escape. In his book, Walking the Tiger, Peter Levine states that there is a great similarity between the animal and the human experience in relation to this reactive or survival response. except that humans find it far more difficult to shake off the residual effects of the immobility response that our animal counterparts can. Many believe that the survival response is activated when the iliopsoas muscle is palpated. Some of us in clinical practice may have experienced overt emotional and or strong reactions from patients or clients who we are treating with direct palpation techniques onto the psoas major and over the pelvic area in general. It could be argued that direct palpatory techniques may trigger reactive compressed energy originating from unresolved trauma present in the iliopsoas. Causes of unresolved trauma may include a history of physical or psychological abuse, family or marriage breakup, or other forms of emotional loss that your client may have experienced. The iliopsoas muscle is an essential part of the instinctive fear reflex, and as such it has great sensitivity. It should also be noted that this muscle is responsible for taking the body into a fetal position to protect the vulnerable organs of the body from a deadly blow or fall. It is not unreasonable then to assume that the iliopsoas is the muscle that holds its reactive response energy to protect the body from harm. Causes of unresolved trauma may include a history of physical or psychological abuse, as mentioned, family or marriage breakup, and your client may have experienced other unfortunate instances that will come to the fore when the area is palpated around the iliopsoas. The fear associated with these events as a reactive response, a reflex response, may be present, and we need to be extremely careful with the techniques we use to palpate this area of the body. I will present a selection of those palpatory techniques later in my presentation. Next slide. Let's walk. Let us be clear about this. The legs do not originate movement in the walk of a balanced body. The legs support and follow. A movement is initiated in the trunk and transmitted to the legs through the medium of the iliopsoas, and so Ida Rolf says. Like Rolf, many consider the spine to be the primary engine of walking. The contention is that an efficient gait is driven by the action of the spine rather than the legs. The psoas major and minor as one unit is the only muscle that connect the vertebral column to the legs. A free pendulum movement of iliopsoas muscle, uninhibited by dysfunction or pain, will give the leg its free swing. The iliopsoas muscle links the vertebral column to the legs, inside to outside, axial to appendicular, and provides the most important initiation of walking. During locomotion, the iliopsoas muscle acts continuously and peaks during the walking cycle. Of the three muscles, iliacus, psoas major and psoas minor, the iliacus provides the major force for anterior propulsion. Next slide, please. Let's breathe. The iliopsoas muscle is closely connected to the respiratory process at the diaphragm, the main muscle of respiration. The iliopsoas has an intimate connection with both the medial and arcuate ligaments, and with the ligaments lying around the top of the psoas minor and psoas major respectively. Both the psoas minor muscle and the psoas major muscle also connect to the central tendon of the diaphragm. Psoas major in particular has intimate anatomical attachments to the diaphragm and the pelvic floor. This unique anatomical disposition allows iliopsoas to act as a link between the diaphragm and the pelvic floor. That may mean that the iliopsoas muscle is very important in stabilizing the lumbar spine during certain phases of the respiratory cycle. Move to the next slide, please. Iliopsoas, innervation and visceral system. Iliopsoas is positioned posterior to the bladder, some viscera and reproductive organs. The kidneys lie each side of the psoas major and psoas minor muscles. It is very important that massage practitioners do not palpate deeply into this region due to the sensitivity of the organs that lie above the iliopsoas here. From the many prosections I have studied over the past 18 months, it is obvious that palpation of the iliopsoas is not possible Therefore, it is also quite apparent that new palpatory techniques are needed to successfully influence and treat a dysfunctional iliopsoas. There is an interrelationship between the iliopsoas muscle and the supplying nerves, in particular the ilioinguinal nerve, which arises from the L1 lumbar vertebra. It emerges laterally from the psoas major muscle and then passes anterior to the posterior abdominal wall, running around the trunk and inferiorly through the inguinal canal. It terminates on the inner anterior aspect of the inguinal region, supplying sensation to this area and the transverse abdominals. It has always been argued that the psoas tightens and may lead to movement dysfunction around the hip and pelvis when dysfunctional, and this can lead to pain around the lower abdomen and inguinal region. We will examine new techniques to address this possibility without eliciting the fear reflex. Next slide. The core. Balancing the core. The core consists of many different muscles that run the entire length of the torso. These muscles stabilize the spine, pelvis and shoulder and provide a solid foundation for movement. Major core muscles include the transverse abdominals, external and internal obliques, and erector spinae. Some argue that imbalance between these muscles can cause back pain. There is also a relationship between the iliopsoas and these core muscles, in particular the erector spinae. Thomas Myers contends that there are 4 gullies around the spine, the erector spinae muscles posteriorly and the iliopsoas muscles anteriorly, filling these gullies and supporting and balancing the lumbar spine. This influence on the core has as much to do with stability as anything else. Representing the iliopsoas as nothing more than a core muscle is limiting in my view, and I would prefer to describe the iliopsoas as the body conductor. Developing a trusting relationship with the psoas conductor will, in my opinion, result in increased clinical success and with the other body structures that are influenced by it. In my view also, kindness shown to the maestro will result in a far longer and sweeter symphony for your client. The iliopsoas muscle is more than a core or a prankster. It possesses the sensitivity of the most talented massage therapist and should be treated with the utmost respect. It will be clinically compliant when bullied by painful overstretching and prodded unkindly, but then go back to where it was before it walked its legs into your clinic. A contracted iliopsoas muscle may stay contracted due to postural habits brought on by a sedentary lifestyle or an unbalanced standing or sitting posture. The way we stand, walk and sit can distort the iliopsoas muscle. A deteriorated iliopsoas chronically flexes the body at the level of inguinal region so that it prevents truly erect posture, wrote Ida Rolf. Sitting through the day, the psoas major muscle can shorten to keep us biomechanically balanced for a seated posture. Over time, we develop a normal way of holding the iliopsoas that is dysfunctional. Unresolved trauma can also keep the psoas short and reactive. Some of the possible causes of a dysfunctional iliopsoas can be, amongst other things, sitting for long periods, postural instability, attempts to avoid falling or a possible injury, and direct physical insult. Next slide, please. Premise on which these techniques and protocols for working on the iliopsoas are based. Presently, I will show you several of the new techniques that I have developed for a dysfunctional iliopsoas. It's important, I think, to look at the premise on which these techniques and protocols for working on the dysfunctional iliopsoas are based. Developing of a caring, pain-free and trusting therapeutic environment is essential for long-term success in treating a dysfunctional iliopsoas. The second point, the major function of the iliopsoas is stabilization, particularly at the distal and proximal connection points of the muscle. Not all agree with this, and certainly some of the textbooks that you will read do not. Perhaps we are looking at some new protocols that do look at stabilization as being one of the major factors in the iliopsoas. The psychosomatic function of the iliopsoas involves possible memory or emotional and/or physical insult of this muscle and or the tissue that surround the pelvic area. Overstretching, direct frictions or other pain-producing techniques over the pelvic area may elicit the fear reflex in your client. The action of heat over the pelvic area and iliopsoas can have a positive therapeutic effect in calming a dysfunctional iliopsoas and is recommended as an alternative to cryotherapy. Some of these techniques are quite new. I hope you enjoy watching them, and perhaps you can pick up a few and use them in your own clinic at some stage. Next slide. The assessment and treatment techniques that you will view are only a selection from several that I would use in my clinical practice. It is recommended that for a more comprehensive practical and theoretical understanding, you may wish to attend one of my workshops or view the Understanding the Iliopsoas DVD, which can be found at worldwideweb.mostlymassage.com. Next slide. Technique 1. By placing a water-filled heat pack on the supine client's pelvic area, you will initiate a warm, comfortable environment. You should describe precisely how you intend working on your client who suffers dysfunction caused by a tight iliopsoas before beginning any treatment. This foundation of therapeutic trust is enhanced by the use of fluid warmth. With your heat pack over the pelvic area, work on the affected side by holding the arm and lower leg while gently bringing the body into a C-curve, compressing the head of the femur into the acetabulum. This technique is borrowed from orthobionomy and is the initial technique aimed at encouraging a feeling of stabilization at the distal connection points of the iliopsoas. Repeat the move slowly and deliberately 5 times. Next slide, please. Technique 2. The stabilizing compression lock, SCL, is another technique aimed at relieving pressure and tightness at the iliopsoas distal connection points. Remove your heat pack and, working on the affected side, flex the knee and hip and slowly externally rotate the leg at the hip. Apply firm but comfortable pressure from the knee to the hip joint as you slowly lock the femur head into the acetabulum. Hold this position for at least 10 seconds. Release pressure and complete this move 5 times. Move to the next slide, please. Technique 3. Gentle Thomas maneuver. This technique continues on from the last and, as you can see, is a gentle approach to performing the sometimes painful Thomas test stretch. Here we use large heated stones to ease, stretch and manually vibrate the tissue from the hip to patella over the quads with the inclusion of essential oils. Oils of choice here are rosemary, basil, wintergreen and clove. Compress the non-affected leg to the chest by flexion of the hip and knee. I may also address the ITB while I'm working here, as well as sartorius with vibration with the heated stone. A word on the use of manual vibration at this point. Static visual representation of this technique underplays the importance of this rarely used massage skill that is the only way to really affect the deeper fascia and muscle tissue of the body, in this case the quads. Next slide. Technique 4. Glide and edge with thermal stone over the iliacus, psoas major and psoas minor respectively. You will be working from the distal to proximal connection points. If your client is experiencing lower back pain around the T12 to L2 area, massage over the lateral edge. If your client complains of back pain around L3 to S1, work on the medial side of psoas major. This therapeutic approach follows Thomas Meyer's theory, mentioned earlier in my presentation. This technique incorporates both heated stones and vibration directly over the iliopsoas muscle. Replacing your fingers with the warm, even stone edge, pressed and vibrating over the iliacus, is a more pleasant and, I would argue, more successful method of addressing this sensitive muscle. Next slide. Client control of treatment. Your client may also be able to control this therapeutic approach by placing their own hand on the thermal stone, with your hand over theirs. This working method may assist in creating trust and avoid initiation of the fear reflex. Next slide. Technique 5. Addressing inguinal pain caused by shortened iliopsoas. The sensitive area between the pubic bone and trochanter can be extremely difficult to address with massage therapy. Using vibration with thermal stone can be a more comfortable way to treat groin pain in this area. You will palpate over the femoral nerve during this process. As we have seen, inguinal pain can be the result of a holding or shortened psoas major that may lead to femoral nerve compression. Again, your client can take more control over the massage process by placing their hand over the stone and below yours. Move to the next slide, please. Technique 6. Ribcage vibration. The intimate connection that the psoas major has with the diaphragm makes it appropriate to work between the intercostal muscles with manual vibration to influence the fascia and muscle that may be tight under your hands and stones. Slowly move the thoracic cage towards the side of the affected iliopsoas and repeat this process 5 times. Next slide, please. Technique 7. Client-initiated iliopsoas stretch. This is a simple but effective stretch that your client can perform while lying on their back. With the client's leg adducted, gently rest the limb on the side of the table edge and allow the lower leg to drop over the side of the massage table. This will gently stretch the iliopsoas muscle. With the application of heat via the medium of thermal stones, this stretch can be very successful as part of the process of relaxing the tight iliopsoas muscle. It can also be performed by your client when they return home. Next slide. These are some of the many techniques that I employ in treating a dysfunctional iliopsoas. These techniques are based on research and meta-analysis of the available literature. Elements of orthobionomy, trigger point, and particularly heat therapy can be successfully employed in the treatment of a dysfunctional iliopsoas muscle, and these are a selection performed with your client in the supine position. Next slide. All the work that you have seen here and on my DVD has been developed to reduce the possibility of eliciting the fear response in your client while you are working on the iliopsoas muscle. Time is not available in this demonstration to present techniques used with your client in the prone position. However, it is important to mention that a major antagonist of the iliopsoas are the gluteal muscles. I would argue that there is no better technique than vibration combined with the thermal stones to reach beyond superficial muscle and fascia to affect this antagonist group. Next slide, please. The same process is also very useful in working on the lower back and on the 2 gully muscles, the erector spinae group. The use of thermal therapy has been shown to increase the success you may have in direct or non-directed stretching routines aimed at releasing a tight iliopsoas. Next slide. A simple stretching program that you may like to have is also available as a booklet from worldwideweb.mostlymassage.com. Thank you for logging on to my presentation on the iliopsoas muscle.
Okay, thank you very much for that presentation, Greg.
Thank you very much indeed.
Scott, are you on the line? Okay. Well, I'm going to go ahead with questions. We have we have some questions from our listeners, and I would encourage listeners, if you have any questions at all about the psoas muscle, great discussion of a muscle. I love it when people dig into something like that kind of topic. It's great. So if you have any questions about the iliopsoas muscle or its treatment, clinical approaches, just type your question in the Q&A box. Just send that my way, and I'm going to tackle a few of these right now. So we have a few interesting questions here, Greg.
Sure, yeah.
David from Hiroshima, Japan,
yes.
asks about, do you have any techniques that address chronic adductor tightness in relationship to iliopsoas work? So do you have any thoughts in terms of the relationship of the iliopsoas and the adductors?
Very much so. In fact, in the presentation, I think I showed there on the slides that I was using those quite large stones on the adductor group, as well as the sartorius and those muscles around that area. I certainly work a lot on that area as a kind of truncated Thomas maneuver, I guess, which I find very useful over those areas. So yes, stones are great. I use a lot of stretching and vibration, which is quite hard to actually show on the slides. But the vibration that I use with the stone, I find very effective in stretching the quads, and I use it in conjunction with my work on the iliopsoas.
Okay. Another question from Barbara Sharp in Atlanta, Georgia, and she's wondering about a weak iliopsoas. Does the iliopsoas have any tendency to get weak? And she asked specifically, can it lead to foot problems?
That's a great question, Barbara. I was down your way at a conference a couple of years ago, and gee, it's nice. Thank you for the question. Yes, it's a question that came up in New Zealand recently. I perform exactly the same treatment that you saw for a shortened or dysfunctional iliopsoas as I do for a weak one. I would suggest that the orthobionomy techniques that I use are extremely beneficial in working on a psoas muscle that is weak. Stretching, I think, too, can very difficult if the stretches are too heavy, and that can further exacerbate a weak iliopsoas muscle. So yes, same techniques as you've seen here and on my DVD will be of as much benefit for a dysfunctional or shortened iliopsoas as a weak one.
So does a shortened iliopsoas cause inhibition of the muscle, do you think?
It causes a possible tightness in the lower back. Of course, that can lead to lower back pain, and it can also cause a truncated walking posture and truncated walking process.
Okay. Another question. Someone has visited the Body Worlds exhibit, where you view those plastinated, dissected bodies, and from this woman, they're fabulous. And from this woman's observation, the iliacus seemed quite thin, and she was wondering or questioning how strong it really was, and she just was wondering what do you see as the role of the iliacus portion of the iliopsoas specifically?
It's the big one for walking. I would suggest to you that these things aren't necessarily proved to a conclusion, but I feel that the iliacus is the one that's used mostly in walking, even more so than the psoas major or minor. And is it small? Well, everyone's different, I guess, and certainly the prosections that I've viewed over the last 2 years have been a huge range of size, but suffice to say that they are all very much connected strongly to the iliac fossa. So the depth of them it varies from person to person, but you know they're a fairly large muscle, and they cover 2/3 of the fossa, so they're not super small.
No. Okay. And it's always interesting when you're seeing dissections like that. We have a sort of an image, that we get from our fingers, but, a lot of massage therapists don't have the opportunity to do dissection. It's always interesting to actually see the muscle that you're feeling. And sometimes there's...
Oh, sorry, but
no, go ahead.
You know what?
Sometimes there seems to be a little bit of a disconnect there from what we feel and what it actually looks like physically.
It is an absolute eye-opener to see a prosection, and I'm lucky enough to go down to the New South Wales Uni, and I do a lot of work down there. The interesting point about the iliopsoas is that it is so deep, and to actually access this muscle with your fingers is really impossible, and you've really got to use other techniques, I believe. The fat tissue itself and the skin is quite thick, and then of course we've got visceral system, and we've got transversus, erectus, abdominis. So we've got a lot of muscles there before we actually get down to the psoas. So in terms of palpation, I think that looking at it from that point of view, you really get a very different idea of what you're actually massaging when you do, which is why I've incorporated vibration and heat so much in my work.
Okay, now along that line about the iliopsoas being hard to access, Terry Kathman from Everly, Iowa asks, what would you suggest to do during pregnancy massages to help release these muscles? She obviously finds it challenging.
I would say that number one, I definitely wouldn't use frictions, and I wouldn't use my fingers. That's the number one contraindication from my point of view. Can you use heat? Well, you know that of course a pregnant client will have a body that's a little bit warmer than one that's not. So using warm stones, they need to be, I would suggest, a little less warm than usual, and perhaps even colder stones are good to use in the area. But it's certainly direct frictions and trying to access the iliopsoas muscle on a pregnant client is I think probably a little bit foolhardy. Perhaps you're much better off working with the lower back and also working with light vibration and, as I suggest, the thermal stones over the area.
Okay, so it seems like you're a proponent for sort of an indirect approach to the psoas, or indirect techniques. Janine
Yes.
Clancy from St. John's, Newfoundland, that's in Canada, asks, what degree of pressure can you use when using the tips of the fingers to palpate the psoas while the hip is flexed and the client is in the supine position?
Janine, that's a great question, and certainly some of the work I do is, and I haven't shown it on my presentation today, but I do flex the knee and flex the hip. How much pressure can you use? Well, I think it relates pretty much to the edge of the finger. That's what we're looking at in terms of the edge that's actually being used as the pressure. So I would say extremely light, and remember that if you're an advocate of what I'm saying, which is that your fingers aren't going to press onto the iliopsoas muscle at all. They are going to press onto other musculature and adipose tissue before they even get anywhere near this muscle. I think that if we're looking at fingers, then we're probably better off using a scalpel, to tell you the truth, which is not recommended for massage therapists, I'm afraid. I really think that you're looking more at bring back vibration. I'm a big advocate for vibration with your hand and with the edge of your hand if you're not using stones. That, I feel, is a much, much better way to work on the muscle itself.
Okay, and on that subject, I have just one more really quick question, because I know we're running tight on time, is what quality of vibration, physical, fast, slow, perhaps more of a mental approach, or even using tools like those in Samvana? All
of the above is pretty good, I think. I would suggest to you, I'll tick box D. I think all those approaches, and every client is different, every practitioner is different, and I really feel that from my point of view, I prefer to use quite a light vibration with the palm edge rather than individual fingers, and certainly that's where I think warmth comes into the equation. How much pressure? It depends on how much pressure you're actually able to apply, I guess, depending on the client. But fingers are a no-no for me. Edge of hand, yes, and light pressure is recommended. Vibration is the way to get down there. You're not going to get down there with direct friction. You'll get down there with vibration, whether it be a light or a deeper method.
Okay, that's great. Thank you so much for addressing those questions, and I understand, again, you're going to hop into the chat room after to answer any other questions that listeners have that we didn't get to here, so that would be very much appreciated. And on that note, I'm going to hand the mic back over to Scott to wrap up for us.
Well, thank you, Eric. I'd like to thank all of our trade show sponsors and invite you to check out a virtual trade show where you'll find lots of great products and service providers to help your business grow. I'd also like to thank Greg Morling. Thanks so much for your presentation. We truly appreciate you taking the time to share your knowledge and expertise. A special thank you, Greg, for all of your patience and being a good sport and trying to get you on the line. We apologize. Some of the slides were out of sync, and that's the great thing about doing something live. So we really appreciate that very much, Greg. Thank you for being part of this presentation.
Thank you, Scott. I actually speak and appear in live walking before I talk, so I'm a bit like my slides, I think.
Well, thanks again, Greg.
Scott.
We'd like to thank our global sponsor, Massage Envy. Massage Envy offers steady client flow, competitive wages and benefits, full and part-time positions, and a respectful, positive working environment. To apply for a position near you in the United States, visit www.massageenvycareers.com. Thanks to our daily sponsor, the National Certification Board for Therapeutic Massage and Bodywork, defining standards and providing certification exams and programs for the professional for over 17 years. Learn about their newest initiative, Advanced Certification, by visiting www.ncbtmb.org. Remember that all presentations, the trade show, and sponsor information for the World Massage Conference 2009 will be available until May 31st, 2010. We invite all full access registrants to download all the presentations to create a resource library of over 60 hours of training for yourself and to take quizzes to obtain your continuing education certificate. For those of you in the United States who require NCB, TMB continuing education credits, please follow the link in the registration area for instructions on how to access your certificate. For our basic access registrants, remember that you can upgrade to a full registration at any time during or after the conference to be able to download presentations, apply for CE certificates, and more. On behalf of my World Massage Conference partners, Eric Brown and Melanie Hayden, I'm Scott Dartnell. We'd like to thank all of our participants and our presenters. Have a great day.